Good evening, everybody. My name is Melithon Polaris. I'm here with United States University FNP 597. Today, I'll be presenting a pediatric mental health case that was particularly meaningful for me as it challenged me to go beyond the physical assessment and to fully gauge with therapeutic communication, really safety assessment, and holistic care. The patient that I had the opportunity to see will go by the names of LO for privacy of this patient and their family. LO was a 14-year-old Hispanic female from Fresno, California, with a chief complaint of I feel numb, and I cut myself to distract from the pain I feel inside. LO for the HPI, she's a 14-year-old Hispanic female. She was accompanied by her mother after being found wandering approximately 1 mile from their home earlier today. LO didn't arrive at school as planned, and the school informed the mother, who then called the sheriff, who found her wandering. When they found her, they did find her with lacerations to her bilateral forearms that at that time were actively bleeding. When she came in, she was initially withdrawn. I was able to change my approach because she wasn't open at that time, and so I really just wanted to provide an environment to listen and where we can establish a rapport and an opportunity for her to open up, which she did. And when she did, she expressed that she's been having depressive symptoms over a year. These symptoms have gotten worse over the last 6 months as her parents had separated at that time. Her father recently, within the last 3 months, moved away and currently lives a few hours away and relocated because of his job. He is currently not involved in her life. She did describe that she has persistent sadness, emotional numbness. She feels hopeless and really has a lack of motivation and doesn't really want to go to school. She did admit she had been intentionally cutting herself, and she had cuts to her bilateral forearms, which is a maladaptive coping mechanism. In addition to her stating that she's distracting herself from the pain she feels inside, she does deny suicidal ideations, plan, or intent at this time, but does emotionally endorse her numbness and hopelessness. Upon inspection, I found a concealed pocket within her left buccal mucosa where she had a razor blade stored. During the visit, she was screened with the PH9Q modified for adolescents, and she had a score of 18, which indicated moderate severe depression, as well as a non-suicidal self-injury screening of the CSSRS, where she was found to be in a moderate suicidal risk due to her self-harm behavior. This case was very meaningful and stood out to my mind because I'm usually able to connect with pediatric patients easily, but this was hard as the patient was withdrawn and initially not willing to speak. And so really allowed for an opportunity to see that there was real emotional distress and really to adapt my approach to try to establish rapport and an open conversation. It was also meaningful in the fact that the physical findings were not the primary issue. And in fact, it was the emotional pain that was hidden beneath the silence. So it challenged me to slow down, build trust, and understand that sometimes it's the connection more than the therapeutic interventions that mean most in the moment. And so it also reminded me about family dynamics and how the absence of a parent can deeply impact an adolescent's mental health, specifically in Hispanic families, which is the general and population which this pediatric office serves. This patient didn't have not taking any medication, not prescribed or over the counter, no known allergies, past medical history, pretty much non-existent, no psychiatric diagnosis, no hospitalizations, no surgery, no chronic medical conditions. Patient family history: the parents separated 6 months ago. The father relocated, is not currently active. There's no psychiatric history on either sides of the family. Regarding social history, she's currently living with her mother. She has started being absent or has been ditching school for the last 3 months off and on. She denies substance abuse, and she does have the psychosocial stressors of her parental separation as well as her father being out of the picture. Regarding review of systems, psychiatric symptoms were positive for depression, hopelessness, emotional numbness, and self-harm. Constitutionally, she appeared thin and pale skin. She had multiple superficial lacerations, but all other symptoms were reviewed and were negative. Vital signs were normal. Her height, she's 5'2", weight 95. Her BMI was 17.4, was slightly underweight for her age. But upon physical exam, she was thin, adolescent female. She was initially withdrawn, but she was cooperative after a rapport was established. Regarding skin, she had bilateral forearms with multiple superficial linear lacerations, 9 in total, left on forearm 5 and 4 on the right. There was no active bleeding or signs of infection. HEENT, the left mucosal mucosa, she had a self-created pocket containing a razor blade. That site was clean, dry, with no erythema or discharge. Neurologically, she was alert and oriented. Psychiatrically, she presented with a flat affect, a depressed mood. She did provide insights to her current behavior. She did deny suicidal ideations, but she is a high risk for suicide because of her current behavior. Primary diagnosis is depression unspecified because she's an adolescent presenting with moderately severe depressive symptoms per the PHQ-9. She has active psychosocial stressors and non-suicidal ideation. Differentials to consider was MDD. Because of her PHQ-9, it supported this, as well as her symptom duration and functional impairment. Non-suicidal self-injury would be the second differential to consider because of repetitive cutting without suicidal intent, as well as her moderate risk for suicide. The third differential to consider would be adjustment disorder with depressed mood related to her parents being separated. But this is less likely due to how long, the chronicity of it, as well as the severity. Thoughts of getting to the working diagnosis was she had symptoms that were over a year. So that ruled out, to me, simple adjustment disorder. The severity of her PHQ-9, it really supported moderate depression. And her behavior, her repetitive cutting, as well as concealing the razor in her cheek, it indicated she had a maladaptive coping mechanism. And so it was not just a situational distress. It's important to note that because of her self-injury, non-suicidal behaviors, she is a future risk for suicide. So the working diagnosis is depression unspecified, F32.8. So the plan is based around safety. Because of her moderate risk for suicide, we developed a safety plan with her as well as her mother to remove all sharp objects and close supervision at home. There was an urgent referral to the adolescent psychiatry, as well as the patient contract was made where she agreed that she wouldn't harm herself, that she would give the interventions an opportunity to help her, and the mother agreed to help her in any way possible. As far as the workup diagnostics, PHQ-9 was done in the clinic, CBC, CMP, and a TSH was done. Treatment for this diagnosis is the first line is psychotherapy. So we referred her also to the cognitive behavioral therapy. Pharmacologically, nothing is going to be done at this time. Really, we'll consider SSRIs if symptoms persist or they worsen, but this should be initiated under a psychiatric guidance. So everything today was focused on education. Educated patient and the mother on signs of depression, as well as self-harm risks. We discussed warning signs of suicide, encouraged open communication and support, and try to introduce healthy coping strategies. Want to see her in 48 to 72 hours, and then weekly until she establishes that referral with mental health services. Regarding Gene Watson's Caritas, I applied number 4 by building a trusting relationship with the patient, especially since she was initially withdrawn. I took time to create non-safe, non-judgmental space, which allowed her to open up about her self-harm. I used Caritas 5 by supporting her expression of difficult emotions like numbness and hopelessness without minimizing it. My care was holistic because I addressed not just her physical findings, but her emotional distress, her family situation, and cultural background. I involved her mother in the safety planning and emphasized mental health support, recognizing that her healing required both medical and psychosocial care. I thank you for your time and for hearing me out this morning. This evening. You guys have a great night.